Hello friends, my screen is visible to everyone, please.
Yes, ma'am.
Yes.
Okay, let's start ectopic pregnancy. Okay. So from where you have actually, what do you think? What is the exact source of ectopic pregnancy? From where you people have been preparing up till now? Ectopic pregnancy.
Ma'am, Green Top guideline and NICE guideline.
Yes, actually, I have combined these two guidelines in these slides. No single point is missing from any of those guidelines, right? Ectopic pregnancy is a very, very important guideline. It's Green Top guideline. It's NICE guideline. Now, in this slides, I have actually combined everything like it is ectopic pregnancy, right? Then it will be pregnancy of unknown location, then it will be miscarriages, then it will be an abortion, right? It is everything. So I think so after the ectopic pregnancy, you people want to have a break after ectopic, right? But it will take almost more than 1 hour or 2 hours, right? Should I proceed?
Yes, ma'am.
Yes,
Okay, just a minute. Okay, diagnosis and management of ectopic pregnancy. This is written here, Green Top guideline, but it's actually not Green Top guideline alone. It's everything mentioned over here. Ectopic pregnancy, everyone knows it's actually a pregnancy which is implanted outside of the endometrial cavity, right? Similarly, in the, like I have done in the molar pregnancy guidelines, similarly, all the facts and figures I have combined over here, right? Incidence in the UK is 11 over 1,000 pregnancies. Incidence in the women attending early pregnancy clinic is 2 to 3%. Risk factors, everyone knows: tubal damage, surgery, infection, smoking, IVF. Actually, there are many types of ectopic pregnancies, like it can be in the cervix, it can be cesarean scar pregnancy, it can be in the interstitial part of the tube, it can be in the corneal end of the uterus. So I have combined all the incidences over here, right? So the incidence of cervical pregnancy is less than 1%. Prevalence of cesarean scar pregnancy is 1 in 2,000. Incidence of interstitial pregnancy is 1 to 6.3. Corneal is 1 in 76,000. We are coming back to that after some time. Just a minute. This is a very simple slide, and everyone already knows that early pregnancy assessment service should accept referrals from this. I will discuss later on. First of all, the symptoms of ectopic pregnancy. Everyone knows that ectopic pregnancy is a pregnancy which is situated outside of the uterine cavity, and it can be anywhere outside the uterine cavity. Its symptoms are abdominal or pelvic pain, amenorrhea or the missed periods, vaginal bleeding with or without clots. Its signs are pelvic tenderness, adnexal tenderness, abdominal tenderness. These three are the signs and these three are the symptoms, right? These are pretty simple things. There's no difficulty about it. Now, what to offer in the ectopic pregnancy? Okay. As I have told you, that ectopic pregnancy can be the tubal pregnancy, or it can be anywhere outside the uterine cavity, right? So when it will be a tubal pregnancy, now transvaginal ultrasound is the diagnostic tool of choice, right? So what is the tool of choice for the tubal pregnancy, please?
Transvaginal scan.
You are not going to choose laparoscopy, because there will be an option, and students are becoming very conscious in this, and they think that yes, we are visualizing the tubal pregnancy exactly with a laparoscopy, so definitely this is the tool of the choice. No, this is an exam question. You have to choose TVS, because guideline has mentioned that TVS is the diagnostic tool of the choice. Laparoscopy is no longer a gold standard for the diagnosis, right? It is an adnexal mass that moves separate to the ovary. That is called sliding sign. That when you will move, when you will be doing the ultrasound scan, and there is adnexal mass that is moving separate to the ovary, that is called tubal pregnancy. In 20%, collection of fluid within the uterine cavity is called pseudosac. Pseudosac is basically not the gestational sac. It is the collection of the fluid which is inside the uterine cavity. In the 20% of the tubal pregnancy, there can be pseudosac inside the uterine cavity. This is not a heterotropic pregnancy. This is just a pseudosac, right? So management of the tubal pregnancy can be surgical, pharmacological, or expectant, right? All these are the management options for the tubal pregnancy. Diagnostic, in this slide, what is the exam question? TVS is the diagnostic tool of choice. Never choose laparoscopy. I have mentioned options for the management: expectant, pharmacological, and surgical, right? Friends, is the full screen is visible to you? Because we are going to talk a lot about lots of figures and lots of numbers. Is the full screen visible to you, all of you? Friend, this is your extended match questions, right? These are 3 scenarios for your extended match questions. We are going to manage the ectopic pregnancy with expectant management. We are going to manage the tubal, this is all we are talking about, tubal ectopic pregnancy. It can be managed with medical management. It can be managed with a surgical management, right? In the expectant, when we are going to choose expectant, when we are going to choose medical management, when we are going to choose surgical management, this I am going to discuss with you about, right? At what point we have to choose expectant, when we have to choose medical, when we have to choose surgical. When the patient is clinically stable, right? In the scenario, patient is not in pain, patient has accidentally diagnosed, patient is totally pain-free, no problem at all, right? Scan has been done and it shows adnexal mass of less than 35 mm. Less than 35 mm means patient is having adnexal mass of 34 mm, right? No visible fetal cardiac activity. Beta HCG is less than 1500 international units. We have to offer expectant management. Expectant management of beta HCG level of 1000 international unit or less and able to return for the follow-up, right? I will tell you that what is this and what is this. Just wait. This is the offer expectant management. When beta HCG level of 1000 international or less, then we have to offer expectant management. We have to consider expectant management if beta HCG level is above 1000 and it is below 1500, right? Here, this has been taken from the Green Top guideline. This has been taken from the NICE guideline. Now I will tell you that how we have to implement this in our scenarios, right? If it is in the scenario, if it is less than 1000 international units, if it is 900 international units, if it is 800 international units, we have to offer her expectant management, right? And if it is more than 1000, but it is less than 1500, then we have to choose consider expectant management. Expectant management means that we are not going to offer her any medicine. We are not doing her any surgery. We will wait and watch, and I will tell you how we will wait and watch, what is the mechanism behind that, and what will be the method while waiting and watching. It will be coming in the next few slides, what we are going to do. But when patient is stable, when adnexal mass is less than 35 mm, no cardiac activity, beta HCG is less than 1500 ml, we are going to choose expectant management. If patient is hemodynamically stable, then we will offer systemic methotrexate. When we will offer systemic methotrexate, beta HCG level is less than 1500, but can be up to 5000. Now let me, anyone can answer. Beta HCG is 1400. You are going to choose medical management or expectant management, because in both the options, I have written less than 1500. What you are going to choose? Patient's level is 1400 international units. I have given the option of expectant and medical as well. What you're going to choose? Anyone can answer this question, please.
Ma'am, medical?
Medical. Okay. Can you tell me the reason behind it? Why medical? Why we are choosing medical? Your answer is absolutely right. We are choosing the medical because there is written offer systemic methotrexate. There is written consider expectant management. Offer is until 1000 international units. After 1000, offer is finished. After 1000, consider has started, right? From 1000 to 1500, consider expectant has started. and less than 1500, offer systemic methotrexate had started. So between offer systemic methotrexate and between consider expectant management, offer is a better option to choose. Consider means you are considering this. Yes, I can consider this should be given or not. But offer means you are in authentic position to offer the patient, yes, confidently, yes, this is an option to offer you. I am offering you this. This is an option for you to choose. Consider means considering your situation, we can sometime consider, we can sometime not consider, right? So between offer systemic and between consider expectant management, after 1000, you will choose offered systemic methotrexate if it is given in the options. If it is not given in the option, then you can consider expectant management, but on priorities, you will choose expectant management, methotrexate, right?
I mean, if
So,
the patient is reluctant for the medical, then we will go for expectant in this case.
listen, in this exam, patient will not be asking anything, probably. The patient will be asking in part 3 only. At that time, the negotiation will start. In this, the only options will be given to you, right? You have to choose between the options. If patient is prioritizing something, then definitely you can consider expectant management. But we are the one who will tell the patient that what is better for her. When these two options will be given, like less than 1000, it is pretty simple to choose expectant management. The gray zone starts from 1000 to 1500, right? More than 5000, there is no difficulty in choosing. You will choose direct surgical. You will not choose any of these two options. Only difficulty in choosing is between 1000 to 1500. And there are two options: offer systemic methotrexate or consider expectant. If the option of methotrexate is given, you will choose this. If it is not given, then you will choose consider expectant, right? Am I clear up till now?
Yes, ma'am.
Okay. Please, at any point, you people will feel that anything is not clear. Please come up.
Ma'am, I want to ask something.
Sure. Anytime.
Ma'am, when there is a beta HCG
Your voice is
level
breaking. Your voice is breaking a lot, actually. Come up again, please.
we will go. Hello?
Yeah, please.
Ma'am, when there is a beta HCG level between 1000 and 1500, then we will go first toward
Just a minute.
medical
BTHCG level
management.
is just a minute. BTHCG level is how much? How much you're saying? Less than 15?
No, 1000 to 1500.
Okay. All right then.
Then we will go for Mithu
Yes.
first.
If it is given. First, you, because both will be given. This will be given and this will also be given, right? But here is the consider.
Okay.
Offer is the better to offer to the patient as compared to the consider, right? So we will offer Mitho. And then if it is not given, then we will consider. But if you will search for this option. First of all, you will search for this. If you will unable to find this option, then you will choose this. But on okay. Certainly that no intrauterine pregnancy, you have to ensure that no, before methotrexate, at the first visit, methotrexate can never be given. Never in the exam scenario, when this is the first visit of the patient and you are not sure that this is a heterotropic pregnancy or intrauterine pregnancy is completely ruled out, you will never choose methotrexate. Because it can be possible that you will give a methotrexate to the patient who is also having an intrauterine pregnancy. Then it will be a disaster. In the first visit, you will never choose methotrexate unless you are quite sure that there is no intrauterine pregnancy. No sensitivity to methotrexate, no significant pain. Whenever pain is here, forget about these two options. In the scenario, you have to search for all these things. In the scenario, first of all, you see pain. Patient is pain-free, right? Forget about this option, surgical. Look for these two options. Then check fetal heart rate. Fetal heart rate, no fetal heart rate. Choose between these two options. If there is fetal heart rate positive, go for the surgical. Forget about these two things, right? Then check the beta HCG level. If it is less than 1000, offer expectant management only. If it is 1000 to 1500, first choose systemic methotrexate. Search for the systemic methotrexate. As I have already told you that in the EMQs, you should be knowing the options. Then you will be going back to the list and you will find out your favored option that you have chosen. If you find out this, click this. If you will not find this, click this, right? If serum beta hCG level is already more, adnexal mass is up to 35 mm, cardiac activity is visible, pain is there, mild pain, moderate pain, severe pain, whatever the pain is this. You will not say patient is having mild pain. What are you waiting for? You're waiting to get pain square. Whenever there is a pain, choose the surgical option. They want you a safe doctor, right? Do not do its and bits like pain is mild, pain is less, pain is more. Pain is there, choose the surgical option. FC is positive, visible, choose the surgical option. And what surgical option will be there? They will be giving you laparoscopy and laparotomy as well. You have decided this, I am going to do surgery. Now what you will choose, laparoscopy or laparotomy? What is the criteria to choose exactly? When to choose laparoscopy and when to choose laparotomy?
Ma'am, when patient is stable, then we will go for laparoscopy. And if unstable hemodynamically, then we go for laparotomy.
Exactly. Patient is in pain, but patient is hemodynamically stable. You are not suspecting that intra-abdominal bleed is so much that patient is getting hemodynamically unstable, right? When there is excessive intra-abdominal bleed and patient is collapsing, you are not going to choose laparoscopy in that patient, right? In hemodynamically stable patients, you are going to choose laparoscopy, and that is a preferable option. Right? When you have decided that, yes, I am going to do laparoscopy. Yeah. First of all, you have made a decision, I'm going to choose surgery. I'm not going to choose medical is crossed, expectant is crossed. You have ticked the surgical option. You have decided in your mind that I have chosen the laparoscopy. Then you will decide that whether I should do salpingectomy, which is the removal of the whole tube, or salpingotomy, which is incision of the tube, and then removing the trophoblastic tissue and closing the tube, remaining the tube intact, that is salpingotomy. How you will decide that salpingectomy is preferable or salpingotomy is preferable? What is the difference between two? How you are going to make decision?
Check the other tube. If other tube is healthy, then we will do salpingectomy. Otherwise, we'll do salpingotomy.
What is the rationale behind this decision exactly?
Because, ma'am, if the other tube is not healthy and we do salpingectomy on the ectopic site, so then she will be having no tube left. And if there's a factor of PID, the other tube is unhealthy, so they will reduce chances of having a viable pregnancy next time. Also,
exactly.
if we do salpingotomy, then there are chances of having ectopic repeated. So preference is salpingectomy, but if the other tube is unhealthy, then we will do salpingotomy.
Yeah, exactly. Actually, for IVF pregnancies, it's better for salpingectomy, right? For the IVF, it doesn't make any difference. Rather, salpingectomy is a better option. But to have a natural conception, again, it is important to have tube there, right? But there are some pros and cons of both the decisions, right? First of all, let me complete this, that methotrexate is a single dose of 50 milligram is given. And okay, we are talking about surgical options. So first of all, let me complete the surgical option. Then I will coming back to the medical and expectant. I have designed these slides in such a manner that you will start expectant from here, right? It will be going in the next slide to complete starting of the expectant management criteria, treatment, and then follow-up. Medical criteria of the choosing medical management, what we have to give in the medical management, how follow-up we are going to do. Surgery, what criteria you have to choose, what is the management of surgical options, how follow-up will be done, right? Now, surgery we are talking about, you have told me you are going to choose laparoscopy on priority in the stable patients, and you have told me that you are going to choose salpingectomy. In women with the fertility reducing factors, contralateral tubal damage, what are the fertility reducing factors? Contralateral tubal damage, previous surgery, previous ectopic, previous PID. Now you will search these findings in the scenario. Before taking any decision, you will look in the scenario that what about the other tube? What about any previous surgery? What about previous ectopic? What about, they may be mentioned in the scenario that she was treated for the vaginal discharge. They will just write this thing. And you are not going to choose, you will choose salpingectomy. Your answer will go wrong. Although you have chosen the right option, you will say, I have chosen the surgery. Why I'm wrong in this question? Because you have just missed the vaginal discharge. They have just write one single word and your whole question will go wrong. You will see the scenario very, very carefully. Every word in the scenario whether it is a contralateral tubal damage, whether it is a previous surgery, there is a previous ectopic, there was a previous PID, and salpingotomy should be considered if any of this you will find in the scenario. And then persistent trophoblastic rate is 11%. Women with a salpingotomy up to 1 in 5 may need further treatment. This is your exam question. If you will do salpingectomy, you have told exactly, absolutely right, that patients who are having salpingotomy, there is a chance that you will not remove the whole trophoblastic tissue, and some trophoblastic tissue can be inside there, and these patients will need further treatment. So these will be 1 in 5 may need further treatment. Now, what is the follow-up after salpingectomy and after salpingotomy? Anyone knows? I have given you 3 whole days to read the guideline. So anyone can tell me that what is the follow-up after salpingectomy and what is the follow-up after salpingotomy?
After salpingotomy, we will do beta surgery after 7 days, and after salpingectomy, we'll do UPT after 3 weeks.
Exactly. It means you have read the guideline in a wonderful way. After salpingectomy, check UPT after 3 weeks. And after salpingotomy, beta HCG at 7 days after surgery, then weekly until negative result. This negative means 0. I will tell you what other negative means. There are other negatives are also coming in other options as well. In the surgical, remember, in the salpingotomy, 7 days, we will do beta HCG and then weekly until it comes negative, right? Clear, everybody?
Yes, ma'am.
Yes.
Now coming to the follow-up of expectant and the medical management, right? Expectant, we have decided the criteria. We have decided when we will offer, when we will consider, right? Now we have decided that yes, we are not going to give her methotrexate. We are not going to do her surgery. We will just do the expectant management. When we have decided that yes, we will do the expectant management, when we are going to repeat the beta HCG, we will repeat the beta HCG on day 2, 4, and 7, right? On day 2, on day 4, on day 7, right? And after her original test, if beta HCG level drops by 15% or more from the previous value on day 2 and 4 and 7, then repeat weekly until negative result. Here negative is 20 international units, right? Here again we are doing repeat weekly. Here also we are doing weekly. Weekly is doing everywhere, weekly, right? But here is negative is 20 international units. This is more value because we have not done any intervention to reduce the beta HCG to the 0 level. We are just leaving it on her own. This is the expectant management. This is the reason this is more value. This is 20 and this is 0, right? But this beta HCG level is going on 2, 4, and 7. In the medical management, we will do levels at the 4 and 7. There is no day 2, right? Day 2, 4, and 7 in the expectant, day 4 and 7 in the medical, and only in the day 2 in the surgical. On the day 7 in the surgical, right? So day 2, 4, 7, day 4, 7, and only day 7. 1 is getting less. 3 times, 2 times, and 1 time. Can anyone correlate all these 3 figures? Any question up till now? I have not seen chat box.
Ma'am, in this expectant management, we are saying that beta HCG will drop by 15%. That means like day 2 will have a fall of 15%, then day 4 will have a fall from the value on day 2.
Yes, yes, yes,
fall 15%.
Yes, exactly. Yes, exactly. From a previous value.
And day 7 will fall from the previous 4-day value.
Yes. Exactly, from the previous value. And if beta HCG has do not fall by 15% and it stay the same, right? If it will not fall by the 15% and stay the same or rise from the previous value, then review the clinical condition and seek the senior advice to decide the further management, right? And in the medical management, the story will change. In the medical management, if the beta HCG, let me charge my device. If level does not decrease by 15%, then we have to repeat the TVS to exclude fetal cardiac activity. Now the exam scenario will come from here as well. You have done beta HCG on day 4 and day 7, right? It is decreased by 15%. You are going to do now weekly test until it is less than 15 international units. This is 15, here it is 20, and here it is 0. Here it is negative result, right? These 3 are different things. In the medical, this is 15. In the expectant, it is 20. In the surgical, it is still 0. If level does not decrease by 15%, then what we have to do? The scenario can start from here as well. right? You do not have to decide expectant management and surgical option. They will say that patient's medical treatment has been given. On day 4 and 7, her beta HCG has also been done, but beta HCG level is not dropping. Now what you are going to choose? You will choose TVS, right? Beta HCG is not decreased by 15%. You will not choose any other thing. You will choose TVS to exclude fetal cardiac activity, and you will choose second dose of methotrexate. Am I clear now? It is not necessary that scenario will start from here. It is not necessary that exam question will be made to check that whether you know how to choose surgical option, you know how to choose medical options, you know how to choose expectant management. Scenario can start from here at this point as well. As I have already told you, they will always take the scenarios from the last parts, from the end of the story. They will always make scenarios from the end, because they know that you have read and you have memorized these parts very well. You have very much taking all these with very much interest, but at here interest is lost, right? You will be saying that
we had an SBA in July exam about salpingotomy, and the answer was 7 days. And to be very honest, I got so confused already. I remember this so many times, but when the question came, I had to literally think of it like for 2 to 3 minutes, and then I figured the answer.
Exactly.
The SBA was there.
Yeah, and in the exam, it is very difficult to memorize these things until and unless we relate with each other. Until and unless, like I have told you, 2, 4, 7 in the expectant. In the medical, remove 2, right? Only keep 4 and 7. In the surgical, remove 2 and 4 both. Only keep 7. These are 3 figures, right? 2, 4, 7. In the expectant, all 3 are written. In the medical, only 4 and 7 are written. 2 has been removed. In the surgery, only 7 is written, 2 and 4 both are removed. How is that now?
Yes, ma'am. Easy to remember.
It is easy to remember. Otherwise, these things are very tricky. And as I have told you, they will make questions from here at the very end of the story. They will make question from here, self-injectomy, check UPT after 3 weeks. Even here, they will say that level is not fallen by 15%. Now what you are going to do? You are going to choose TVS. You're not going to choose beta HCG or UPT or anything. You will choose TVS plus second dose of methotrexate. Now the success rate of medical treatment is 65 to 95%, and only 20%, 27% requiring second dose. Adverse effects are bone marrow suppression, pulmonary fibrosis, pneumonitis, liver cirrhosis, renal failure, gastric ulceration, right? And in the expectant, if beta HCG does not fall by 15%, stay same or rise from the previous value, here what you are going to choose. Review the clinical condition and seek senior advice to decide further management. This option will be given to you in the EMQs, but you will just overlook this because you will say that this is not important to choose. They are not doing anything. They are doing anything. They are doing the most important thing. This is what they have recommended, because they will make a question from the guidelines. If level is not falling, what you are going to choose? You are going to choose review clinical condition and seek senior advice for further management. This is what you are going to choose here. If level does not fall by 15%, if level doesn't fall by 15%, you are going to choose here TVS for FCA, to exclude FCA, and second dose of methotrexate. How is all management of ectopic pregnancies now, my friends? Who is there with me?
And ma'am, after surgical treatment, if it does not come out to be negative, then we will just keep repeating, or we do some intervention?
Self-injectomy
or salpingotomy if it turns out to be positive?
Yeah, let me tell you. Actually, self-injectomy, it is not possible that it will not come back to 0 or it will not become normal, because we have removed the tube, the whole tube, right? Right?
Because
and in
here
the
they mentioned that women having salpingotomy may need
1 in 5. 1 in 5 may need further treatment, right?
That will be medical management.
No, let me tell you. Of these 1 in 5, persistent trophoblastic rate is 11%. Now it will depend upon how much tissue has been left. Like if somebody who is not experienced has done the salpingotomy and she has or he has left a lot of tissue, then maybe most probably she will be needing medical management, right? But we cannot 100% say that medical management will be effective. Most probably she will need the medical management, and after methotrexate, the trophoblastic tissue will finished, right? But if it will not be removed, then definitely she will need further surgery, right? Repeat surgery may be required. But 1 in 5 will need further management. This is the reason they have told the further treatment. They have not told what will be the exact treatment, because it will depend upon the remaining amount of the tissue and remaining beta HCG level, remaining condition of the patient, right?
Yes, ma'am.
Now, these are very simple things. This was the management of exactly the tubal pregnancy. Now the cervical, let me check who is with us. Irsa, you are here, right?
Yes, ma'am. Yes.
Okay, and Sidra here. Okay. So the cervical pregnancy is actually, these are the all other pregnancies, cervical, interstitial, these are less coming, but I have made separate slides for them so that you will not miss anything for exam, right? Cervical pregnancy is which is inside the cervix. Everybody knows the uterine cavity and the cervix, right? So ultrasound criteria is that definitely when the pregnancy is inside the cervix, then uterine cavity is empty. Cervix is a barrel shape because it is filled with the pregnancy. Gestational sac is present below the level of internal os, because above the internal os, there is a womb or there is a whole uterine cavity. So sac will be definitely below the level of internal os. Now the sliding sign will absent. It means that when there will be TVS probe is going inside the vagina and it is moving, if it will be a gestational sac which is lying inside the cervix of uterine pregnancy, it will move. But when there will be an implanted pregnancy inside the cervix, it will not move. So sliding sign will be absent. And blood flow around the gestational sac using color Doppler. Now, what is the management of the cervical pregnancy? Medical management with methotrexate should be considered. For those, we have to choose medical management. For those with life-threatening bleeding, surgical management should be considered. In exams, you are going to choose medical management, right? Because this is only for those who are hemodynamically unstable. Otherwise, you are going to choose medical management for all the patients who are having cervical pregnancy. Am I clear about it? About the cervical, what you're going to choose? Medical management only.
Medical management.
Okay. Caesarean scar pregnancy, it is 1 in 2000. Now, what is the diagnostic? Where is the caesarean scar? In the lower part of the womb, right? Everyone knows where is the caesarean scar. So what ultrasound criteria we will see? Uterine cavity will be empty. Gestational sac will be located anteriorly at the level of internal os, embedded at the site of previous scar. Now, when the pregnancy will be inside the myometrium or inside the wall of the uterus, then definitely, just a minute, then definitely the myometrium will be thin around it, right? Between the gestational sac and the bladder, because the lower segment of the uterus where the scar was given, it was a thin part of the uterus. When there is a gestational sac located, then definitely the myometrium will become thin between the gestational sac and the bladder, because what is behind the lower part or the caesarean scar of the pregnancy, there is a bladder. So definitely that will be a thin part. Then the prominent placental circulation on the Doppler and empty endocervical canal. Empty uterine cavity, empty cervix, because the cervical pregnancy, caesarean scar pregnancy is located in between these two locations. Uterine cavity is also empty, endocervical canal is also empty. Now, this is a question in your practice book that what is the imaging modality? MRI is the second line if TVS is inconclusive. It means TVS is for everyone. But second line you should be knowing, because this is asked in the practice book, that if TVS is inconclusive, MRI is the second line. And what you have chosen in the cervical pregnancy? Medical.
Medical management.
Medical. What you're going to choose in the caesarean scar?
Surgical management.
Surgical. Never ever medical. Don't choose the medical option. Interstitial pregnancy. Interstitial pregnancy, what is the interstitial part actually? Interstitial part is the part of the tube which is entering inside the uterus, right? From its origin, like the origin of the tube, which is partially inside the uterine cavity and is partially outside, right? So the thin part of the fallopian tube, which is inside the uterine cavity, that is the interstitial part, right? These are the difficult pregnancies, interstitial pregnancies and the corneal pregnancies. But you have to just remember medical or surgical. Medical or surgical, this is the thing you have to remember for your exam. Empty uterine cavity, definitely pregnancy is not in the uterine cavity. Sac is located laterally in the interstitial or the intramural part, surrounded by less than 5 mm of the myometrium. Why? Because the tube is entering in the uterus, right? That is a very thin part of the myometrium. Only less than 5 mm of the myometrium will be all around the tube. This is the tube, and it's around, myometrium is very thin, only 5 mm. After that, the uterine wall will begin and uterus will become like thick myometrium. Interstitial line sign. Interstitial line sign means from the uterine cavity, there is a line going inside the tube because there is a pregnancy inside. So on its both sides, there is empty space. So you can see the line of the fluid going from the uterine cavity to the fallopian tube. It is the thin echogenic line from the uterine cavity to the periphery of the interstitial sac. What is the management option for this? Laparoscopic corneal resection or salpingotomy. You are not going to leave any of this pregnancy to heal on its own by the expectant or by the medical management, but by the surgical management, by the laparoscopic corneal resection or salpingotomy, right? This is the interstitial and corneal as well. For the corneal and interstitial, almost both surgical management by the corneal resection or salpingotomy. Until and unless they are giving a very low beta HCG level, until and unless they are saying the patient is completely stable and beta HCG is extremely low, otherwise always surgery. Medical we have chosen up till now only for the cervical pregnancy. Now the cesarean scar pregnancy is 1 in 2000, right? And diagnostic criteria is that empty uterine cavity, this is already done. Corneal pregnancy. Corneal pregnancy is that visualization of the single interstitial portion of the tube in the uterine body. Gestational sac is separate from the uterus and completely surrounded by the myometrium. A vascular pedicle adjoining the gestational sac to the unicornuate uterus. Cornu means that another horn of the uterus is there, right? It means that it's the unicornuate uterus with another horn, right? And excision of the rudimentary horn by the laparoscopic or laparotomy. Everywhere we are choosing the surgery. Remember, right? Surgical management is more effective. Cesarean scar pregnancy, we have chosen the surgical management. Interstitial pregnancy, we have chosen the surgical management. Corneal pregnancy, we have chosen the excision of the rudimentary horn by laparoscopy or laparotomy. Now abdominal pregnancy, absence of intrauterine sac, absence of the complex adnexal masses. Now, what is the abdominal pregnancy? How you are going to choose? When you insert the TVS probe, you will see that the sac is moving a lot because sac is lying freely inside the abdomen with attached any of the loop of the bowel. Now, how is the management? In early pregnancy, laparoscopic removal. In advanced pregnancy, if significant hemorrhage is there, definitely you are going to do laparotomy. You will open the tummy of the patient and you will remove the abdominal pregnancy, right? It will be either laparoscopic removal or it will be laparotomy. Now, ovarian ectopic pregnancy, minimal access surgery is now treatment of choice for the ovarian ectopic, removal of gestational sac by enucleation or wedge resection if large ectopic. Normally, it is also removal. Now, you want to preserve the ovarian function, right? So what you are going to do in the ovarian ectopic, if in the scenario there is excessive hemorrhage or hemodynamically unstable patient, definitely you are going to choose laparotomy. Otherwise, minimal invasive, minimal access surgery or the laparoscopy, and then you will remove the sac by enucleation or by the wedge resection because these are the young patients, and as much as possible, you want to preserve the ovarian function. What is the idea about the NTD? I have already told that in the molar pregnancy, it is pretty simple that whether we have to choose NTD or not. But what about ectopic? What we have to choose? NTD or not? This is a huge controversial point. Anyone has idea?
Ma'am, in both ectopic and molar, we give NTD. But if they have mentioned that the type of molar pregnancy, that is complete molar especially, then we will not give.
But if until 72 hours it has not yet decided, then we will give, right?
Then we will, yes. Then we will.
Actually, histopathology reports take longer, so we give every patient.
Yes. But if they have mentioned, right, that histopathology has done something like this, then you will not give because they have already also mentioned. What about ectopic?
If it has been managed surgically, then we will give all patients. And if bleeding is heavy, then also.
All patients or only surgical patients?
Ma'am, not for those who have been managed expectantly.
No, I'm asking what about medical and what about surgical?
Ma'am, we will give to all patients who have been managed surgically.
And we should not give to those who have been managed medically?
If there is risk of hemorrhage, there has been major bleeding, then yes, we will give. But if there has been no bleeding and she has been managed expectant, then we don't give it. Medically, I think we can consider.
Actually, listen, actually for the NTD, we usually follow the British Committee of Hematology guideline, right? Normally for NTD, we follow that. But when the guideline of the Green Top guideline has given its recommendation, then definitely we have to follow it. I have compared these two standards over here so that you can have a pretty clear idea about it, right? This is the screenshot has been taken from the guideline, which is basically a British Committee of Hematology. It says that we have to give 250 minimum dose of 250 international unit NTD should be administered to all cases of ectopic pregnancy, right? They have told to all cases, and they have also mentioned that authors note that the recent NICE guideline specifically recommend against offering NTD if ectopic pregnancy is solely managed medically, but without any clear evidence to support it. The author feel that this potentially for causing confusion. Therefore, we based our recommendation upon RCOG Green Top guideline and introduced complexity without making any strong evidence to support such change. It means that they are saying that give NTD to everyone, right? But this is on the other hand side, offer NTD prophylaxis. This is the recommendation by the Green Top guideline, and we have to follow for the exam. If the Green Top recommendation is there, we have to follow that. To all RHD negative women who have surgical removal, right? Or when bleeding is heavy, in the scenario, when bleeding is repeated, when bleeding is associated with abdominal pain, right? Now, irrespective of the mode of management, if the bleeding was heavy, if the bleeding was repeated, if there is abdominal pain in the scenario, you have to pick the NTD, right? If there is bleeding is not heavy, if the bleeding is not repeated, if there is no abdominal pain, right? And patient is being managed medically or expectantly, then no need to give NTD. And if patient is managed surgically, then you have to give NTD. So what are your thoughts now? This is what Green Top guideline says. Agree? Am I clear now?
Yes, ma'am. So we will not choose the option of giving to all the cases of ectopic.
Yes. No. We have to follow the Green Top guideline, right? This is all about the Green Top guideline. Okay. Now comes pregnancy of unknown location and miscarriages according to the NICE guideline. Actually, in the NICE guideline, there is a word which is mentioned, early pregnancy assessment services, right? These all are very important for the part 3 because you should be knowing what is their service structure and what is their idea about doing their work and referral system and everything like this. But early pregnancy assessment services are the regional services and should be organized so that early pregnancy assessment service is available 7 days a week for a woman with early pregnancy complications, right? And early pregnancy assessment should be dedicated by the healthcare professionals, and they are offering HCG, they are offering everything. Now, this is a complete slide for many extended match questions, right? On this side, I have written scenarios, and on other side, I have written what you have to choose. Because in the extended match question, there will be a lot of options. Immediate referral, routine referral, early referral, send back to home, right? Direct referral to accident and emergency, direct referral to early pregnancy assessment services. There will be a lot of options. How you have to choose among those options. Now read these options from there. These are the 4 scenarios that I have made for you, and these are taken from the NICE guideline. Women with a UPT positive and the pain and abdominal tenderness, right? UPT is positive, pain and abdominal tenderness is there, or pelvic tenderness or cervical motion tenderness. It means 3 types of tenderness is there. Along with UPT is positive, pain is also positive. Immediate referral to the early pregnancy assessment service. You have to choose immediate referral. No routine referral, no sending back to home. Immediate referral to early pregnancy assessment services. When the scenario is given that women with a bleeding or pain or pregnancy of 6 weeks or pregnancy of uncertain gestation, you have to refer to the early pregnancy assessment services, but not immediate referral, not emergency referral. Urgency of the referral will depend upon the clinical scenario, clinical situation, right? But if there is bleeding only, pain only, pregnancy of 6 weeks or uncertain gestation, but you are not sending this patient back to home, right? This is not the patient suitable to go back to home. Women with a pregnancy of less than 6 weeks who are bleeding but not in pain and have no risk factors. Like these are pregnancy of less than 6 weeks. They are bleeding, but they are not in pain and no other risk factors. Send home with expectant management. Nobody is choosing sending home because you think that she is pregnant, she is bleeding. No choice of going back to home. But according to NICE guideline, according to Royal College recommendation, you can send the patient home. You can't send the patient back to home. If patient is less than 6 weeks, she is bleeding but without pain. Pain means ectopic pregnancy. There is no pain, there is no risk factor, no previous ectopic, only mild bleeding, only less than 6 weeks, you can send the patient back to home. UPT after 7 to 10 days and come back if positive. And while sending home, you will tell her that she will do her UPT after 7 to 10 days. And when her UPT will become negative after 7 to 10 days, she will come back. She will become, if her UPT will become positive, she will come back. Women who is hemodynamically unstable or in home, significant concern about the bleeding or pain, extreme pain, severe bleeding, directly refer to accident and emergency. How about these 4 scenarios? Any question in these?
Ma'am, there is one thing to notice in these above 2 scenarios, that in the first scenario, the UPT is positive and along with that she has pain. But second scenario, they say that she has bleeding or she has only pain. That means UPT is not comes positive. So then we can send her to early procedures, only refer her. It's not immediate. But if UPT is positive and with that she has pain, then we send her immediate.
Actually, this is exactly taken from the NICE guideline, but my perspective is that because this is a discussion that is going on between you and me, what I perceive here is that the tenderness, they are taking it very seriously. Can you see? Abdominal tenderness, pelvic tenderness, cervical motion tenderness. These 3 tendernesses are pointing towards some sort of ectopic is there.
Immediate care. And in the second scenario, she does have pain, but we are not sure about the UPT because either of these things, either she has bleeding or she has pain or only pregnancy is there, nothing else. So we will refer
Pregnancy
her.
is, yeah, no, listen, UPT is here as well, but pregnancy is also here. They are knowing that she's pregnant. They are knowing she's pregnant. They are knowing she's having pain or
They mentioned or in between each of these.
Yes,
Or.
yes, yes.
But in the above scenario, there is UPT
Yes.
and she has pain.
Yes. These are combination of pain, UPT and tenderness. All these things, right? This is, she's having bleeding or pain or 6 weeks, right? Or uncertain gestation. They are referring, they are not sending her home, right? In this way, they are sending her home. This is a pregnancy of less than 6 weeks and she's bleeding. This is a scenario in the book. I don't know exactly which book is this, but this is a scenario. And we people are very afraid of sending her home. But no need to get afraid when they have recommended less than 6 weeks and bleeding. These 2 combo, we can send back home with UPT after 7 days. This is not after 3 weeks. Remember, 3 weeks is after miscarriage and abortion, right? This is after 7 to 10 days, right? And serum beta HCG in ectopic 247, 47 and 7, right? 247 for expectant, 47 for medical, 7 for surgical. How about that 247 thing? I think it would be easy to remember. And this is pretty simple. Hemodynamically unstable or significant concern about bleeding and pain, refer directly to accident and emergency, right? Okay. Viability of the pregnancy, pregnancy of unknown viability, pregnancy of unknown location. While determining the viability, first look for the fetal heart sound, fetal heartbeat, right? These are again the exam scenarios which are coming, pregnancy of unknown location. These are also taken from the NICE guideline. Just a minute. Irsa and Sidra, you have seen a lot of practice books with these questions, right?
Yeah.
You have seen, right? When determining the viability, when see the scenario, first of all, you see the FCA, right? No FCA, no fetal cardiac activity. CRL is given. Only measure the gestational sac if fetal pole is not visible. If no visible fetal cardiac activity and CRL is less than 7 mm with TVS, there is a TVS you have to look forward, and this is the size of CRL you have to see. Cardiac activity is already not there, right? This is a pregnancy of unknown location. We are not unsure about the viability of intrauterine pregnancy. What we have to do? Fetal cardiac activity is no more visible. CRL is less than 7 mm. like it is 6 mm, it is 5 mm, it is 4 mm. And we have done TVS. This is on TVS. We will perform, what we are going to choose. Perform a second scan a minimum of 7 days after the first before making a diagnosis. This is we are going to choose. Options will be given there. Perform a second scan after 14 days, perform a second scan after 1 week, after 2 weeks, after 3 weeks, UPT after 1 week, UPT after 2 weeks. What you are going to choose, perform a second scan after 7 days after the first before making a diagnosis, right? No visible FCA and CRL is 7 mm or more on TVS. In the previous slide, CRL was less than 7 mm. In this slide, CRL is 7 mm. When they have reached the cutoff of 7 mm, then you have to choose among these, both you can choose. You will always search, ma'am, this is again on the TVS. We have to perform, everyone knows that we have to perform a second scan 7 days after the first before making diagnosis. But if this option is not there, you can also choose this one. Nobody is choosing this. Seek a second opinion on viability of the pregnancy, because there is written or. Seek a second opinion on viability of pregnancy, and or you can choose either combo of these two, or you can choose either of these two. Second opinion on viability of pregnancy can also be chosen when the scenario is given that there is no visible FCA and CRL is 7 mm or more on TVS. You can also choose this as well, right? If no visible FCA, when CRL is measured using trans-abdominal scan, then everyone knows they record the size of CRL and perform second scan after 14 days. After TVS, how many days we are going to scan? And after trans-abdominal, how many days we are going to do a scan?
After TS, we'll repeat after 7 days, and after TAS, after 14 days.
Yes, but it is if it is less than 7 mm. When it is 7 mm, IRSA and Sidra, can you tell me that what we are going to choose if it is 7 mm?
Then we'll seek for second opinion, or we can repeat after 7 days.
It means
both
can choose. We can choose both of these. Second opinion can also be chosen, right? See in the next slide again. If it is fetal pole, we perform second scan 7 days after the first before diagnosis. If gestational sac, actually there's a screen is covered. No visible fetal pole, perform a second scan 7 days after the first before making the diagnosis. Similarly, in the gestational sac, if we have already decided that first of all, we will check the fetal cardiac activity, and then we will measure the CRL. If fetal cardiac activity is no more there, we will check the CRL. If CRL is not more there, then we will check the gestational sac. If fetal pole is not visible, we have already decided. So these are the scenarios about the CRL, which cutoff is 7 mm. And these are the scenarios about the gestational sac. If gestational sac is 25 mm or more on the TVS and no more fetal pole is there, seek a second opinion on viability of the pregnancy and or perform a second scan after 7 days. Second opinion or 7 days. If no visible fetal pole and gestational sac is measured with trans-abdominal scan, record the size of gestational sac and perform second scan minimum of 14 days after first before making the diagnosis. So everyone is clear about it. So can I ask you, Sidra, if sac is 24 mm, right?
Yes, ma'am.
On the TVS, what we are going to choose? And no FCA, no fetal pole?
And we can do scan after 7 days. Minimum of 7 days. Minimum of 7 days. If less than 25 mm. But if 25 mm or more, then we can take second opinion on the viability, or we can perform a 7-day scan, or we can take both of these points.
Wonderful. Exactly. Excellent. You have mentioned 3 options, either this, or combo of these two, right? Any of these we can choose. And with the trans-abdominal, 14 days will come, right? Okay, now pregnancy of unknown location, how we are going to do HCG measurement, right? Beta HCG measurement. Pregnancy of unknown location will have an ectopic, could be an ectopic pregnancy until the location is determined. Now, whenever the scenario of pregnancy of unknown location is come, we are going to check serum beta HCG, right? We have done the scan and we are unable to find out where the pregnancy is located. We are going to do serum beta HCG measurements, 2 beta HCG measurements, and after 48 hours apart, right? to determine the subsequent management of the pregnancy. 48 hours, we will not decide when the patient come to us. 48 hours, we will decide when the first beta HCG measurement has been done. Second beta HCG will be done 48 hours after the first. For the women with increase in beta HCG greater than 63 and less than 50%, everyone knows these two famous figures, right? If more than 63% after 48 hours, what we are going to do? Patient has come to us. We are unable to locate the pregnancy. She's a diagnosed case of pregnancy of unknown location, right? What is our next step? Next step is to check her serum beta HCG after 48 hours from the first level, not from the diagnosis, not from the arrival, not from the TVS. From her first from her first beta HCG, we will check the two levels of the beta HCG after 48 hours interval. For women with increase in beta HCG level greater than 63%, what we are going to choose? How we will know in the exam that this is more than 63%? How in few seconds you are going to choose in the exam? Sidra, how you are going to choose?
Ma'am, if there is an increase in beta HCG level greater than 63% after
How you are going
48
to choose
hours,
in exam, my dear, that 63 is there?
ma'am, we will offer the TVS.
They will just write you the value of the beta HCG. They will not mention that it is 63% rise or not.
If it is more than double, then that means it's about 63%.
Yeah, rough idea is this, it is more than double. If it was like 700 or 7,000, it will be 14,000 or more than 16,000. You can say it is more than 63%, right? When it is more than double, right? Yes, Sidra, you were telling what we are going to do if it is more than 63%.
We will tell her that the pregnancy is likely to continue, and we offer the TVS between day 7 and 14. Here is the between 7 day and 14 day.
But if beta HCG levels are 1500 or more, then even we can choose before 7 days, like between 4 and 7 days, right? Before
Yes.
7 days. Right? If viable, because see, listen, when beta HCG is repeating and beta HCG is increasing, then we will counsel her that this is more likely an intrauterine pregnancy, because in ectopic, it will be falling trend. In intrauterine pregnancy, it will be rising trend. So it means when it is doubling is more than doubling, it is more than double, then it means it is more likely intrauterine pregnancy. So we will do a TVS, right? Now, third beta HCG will not be done. When we are suspecting it is intrauterine pregnancy, then we have to locate the pregnancy again. That where was the pregnancy that we were missing at the very first instance? We were missing here, right? We are unable to see where the pregnancy, we were not able to find. This is the reason we have done beta HCG. Now we are knowing that yes, it is somewhere. It is increasing in size. We are missing somewhere. So we will do the TVS. On day 7 and 14, between day 7 and 14, and on earlier, if the day is more than 1500 or more, if viable intrauterine pregnancy is confirmed, we will offer routine antenatal care. If viable intrauterine pregnancy is not confirmed, we will refer her for immediate review by the senior gynecologist. And believe me, they can make the scenario from the last line, right? They can say that TVS has already been done, but intrauterine pregnancy is still not confirmed. What you are going to choose? Immediate review by the senior gynecologist in early pregnancy assessment units, right? You will choose this now. For women whose serum beta HCG is greater than 15. Can anyone read this for me, this line, if it is visible to you?
For women
with the
okay, so you read.
Yes, for women with decrease in serum beta HCG level greater than 50% after 48 hours, then what will we do? We will inform her that pregnancy is unlikely to continue, but this is not confirmed. We will take DUPT 14 days after the second serum beta HCG. If it is negative, no further action is required. And if it is positive, she would need to return to early pregnancy unit services for clinical review within 24 hours.
Now, Sidra, listen, in the previous scenario, what we have done after 48 hours beta HCG, we have done TVS because we were suspecting that pregnancy is growing somewhere. Pregnancy is increasing in size somewhere. This is the reason beta HCG is more than double. Here we are suspecting that pregnancy is unlikely to continue or some falling trend in the pregnancy. Pregnancy is going to disappear somewhere, but we are not confirmed. Here we will do UPT, right? We are not concerned that it is ectopic, it's going to rupture some fine day. So here we are less concerned. This is the reason we are doing UPT. UPT 14 days after the second serum beta HCG. Beta HCG interval is 48 hours. And after beta HCG, we will do UPT after 14 days. If the test is negative, no further action is required, right? But if test is positive, you need to return to early pregnancy assessment unit services for clinical review within 24 hours. Do not ignore these last lines. They can make questions from there as well, right? Now the scenario for women with decrease in serum beta HCG level is less than 50%, or not more than, or not increase is less than 63%, like inconclusive, not falling more than 50% or not increasing more than 63%. Refer her for clinical review within 24 hours. In pregnancy of unknown location, do not use serum progesterone to diagnose viable pregnancy. In this scenario, when it is not increasing more than 63%, and when it is not falling less than 50%, in this case, we will just send her for review. So for the first scenario, what we were doing, TVS, right? 48-hour serum beta HCG has been done, more than 63% rise, we are offering TVS because we are suspecting somewhere pregnancy is growing on. We have to figure it out so that pregnant patient will not collapse because of ectopic pregnancy. Now, in this scenario, we are not suspecting a uterine any growing pregnancy, so we will do UPT after 14 days. TVS, how many days after we are doing? Between, say, day and 7 and 14. And when UPT we are doing? 14 days, right? After 14 days. If it is negative, no need for any intervention. If it is positive, she will return to early pregnancy assessment services. So these are clear, right? Now we will start with the miscarriage. Miscarriages can be threatened miscarriages. Advise the women with a viable bleeding and confirmed intrauterine pregnancy with a fetal heartbeat that if bleeding gets worse or persists beyond 14 days, she should return for the further assessment. If bleeding stops or should start or continue routine antenatal care, right? Okay, now what is the management of the miscarriage? Again, management of miscarriage, threatened miscarriage. This is the threatened miscarriage, right? These are the patients who are having viable intrauterine pregnancy, confirmed intrauterine pregnancy with fetal heartbeat, but they are having vaginal bleeding, right? We can say them that if their bleeding is get worse or persist beyond 14 days, she should return for the further assessment. But if the bleeding stops, she should start or continue her routine antenatal care, right? And for the miscarriages, if there is a miscarriage happens, we can offer her treatment for expectant management as well, medical management as well, and the surgical management as well, right? In every aspect of the treatment, I will be telling you that what sort of miscarriage we are offering these treatments, right? As I have told you that expectant management is the first line management for miscarriages. Use the expectant management as a first line for 7 to 14 days for women with a confirmed diagnosis of miscarriage. Patient is confirmed diagnosis of miscarriage, right? We have done the ultrasound scan. Patient came with a bleeding. We have confirmed that FCA is also not positive. Patient has already miscarried and patient is mild bleeding. We will offer her expectant management because this is a first line management for 7 to 14 days. And after that, we will tell her to perform UPT 3 weeks after the miscarriage if the resolution of the bleeding pain indicates that miscarriage is complete, right? And if bleeding and pain persist, we will tell her to repeat her scan. Now, what is the medical management? Do not offer mifepristone in the missed or incomplete miscarriage, right? Mifepristone, what is mifepristone exactly, by the way? Anyone is knowing what is the mifepristone? Mifepristone is actually block the progesterone receptors and it blocks the pregnancy to grow, right? So there is no need for prescribing of mifepristone. And we have to offer vaginal misoprostol for missed or incomplete miscarriage, oral if the women's preference. Now come to the exam scenario. Listen, in the incomplete miscarriage or in the missed miscarriage, these both options will be given to you. Vaginal misoprostol will also be there. Oral misoprostol will also be there. What you are going to choose in the exam? You will choose vaginal because they have offered vaginal. Oral in only in that case if women is not comfortable with the vaginal misoprostol. If women is not comfortable with the vaginal misoprostol, then you will offer oral misoprostol. Otherwise, among these two, if both options are there, you will tick vaginal misoprostol for missed or incomplete miscarriages. And you have to use single dose 800 microgram of misoprostol for missed miscarriage and single dose of 600 microgram of misoprostol for incomplete miscarriage. But you will not choose combination of mifepristone and misoprostol. And surgical is MVA, right? Manual vacuum aspiration under local anesthesia in outpatient or the clinic settings, or the surgical management in the theater under general anesthesia, right? Now, surgical is finished over here. No more follow-up and no more we are going to do until and unless we are going to do 3 weeks UPT, right? Now, expectant and the medical is going on. In expectant, if the bleeding has not yet started, we have sent the patient home for 7 to 14 days, right? We are doing it as a first line option. This management, expectant management, we have sent the patient home back with the bleeding. And we have told her, we will do your UPT after 3 weeks. Now, the bleeding has not yet started, or it means the process has not begun. Woman is not suitable for expectant management. Patient at increased risk of no, this is the end of the story. If patient is not, offer repeat scan. If bleeding and pain persist or increase, in this case we will offer repeat scan. We have sent the patient for 7 to 14 days, but in between patient came back with increased bleeding or increased pain, or it is increasing or persisting, we will offer her repeat scan. We will see exactly where the pregnancy is and what is going on exactly. Or if the bleeding has not yet started, or the process, it means process has not begun. If the bleeding has not yet started, means maybe the pregnancy is ongoing pregnancy. Pregnancy is not being miscarried, right? So the women who are not suitable for expectant management, this is the criteria. This is you have to rule out in the exam scenario. Then you will choose among these options. Medical, expectant, medical, or surgical. If any 4 of these you will find, you are not going to tick the expectant management. You will not choose the expectant management for these patients. If patient is bleeding and early stage of the pregnancy, but at increased risk of hemorrhage, in the late first trimester, what is mean by the late first trimester? First trimester up to 12 weeks, right? So after 6 weeks, after 8, 9, 10, 11, 12, these are the late first trimester, right? 8, 9, 10. From the 8 weeks onward, this is the late first trimester miscarriage. So at that time, from 8 weeks onward, you are not going to choose expectant management. There is no cutoff given, but this is a common sense that the late first trimester will be around the end of the first trimester. Patient with previous adverse experience like previous APH, previous miscarriage, previous stillbirth, you are not going to choose expectant management. Patient with coagulopathies, not willing for blood transfusion like Jehovah's Witness or having coagulopathy, you are not going to choose expectant management. Patient with infections, you are not going to choose expectant management. Now the medical management was going on. We have offered her vaginal misoprostol. If her preference is there, then only we will offer oral. Otherwise, we will offer vaginal misoprostol. Dose we have decided 800 microgram of misoprostol for missed miscarriage and 600 microgram for incomplete miscarriage, right? We have decided. Now what follow-up we will do? We will advise that if bleeding does not start in 24 hours, she should contact her healthcare professionals to determine ongoing management and advise her UPT after 3 weeks after the medical management. If worsening of the symptoms, return to the healthcare professionals responsible for their management. UPT we have advised after 3 weeks. If UPT comes positive after 3 weeks, return to the healthcare professionals to ensure no molar or ectopic pregnancy is there. And along with that, along with the meso that we have given her, vaginal misoprostol 600 or 800, whatever dose we have given her, we will give her pain relief. We will give her antiemetics. This is must with the medical management. Whenever you will choose the medical management, choose whole management. This is the complete management package. Medical management, meso, vaginal or oral, whatever dose you have chosen, pain relief plus antiemetic. These 3 will be the complete management and UPT after 3 weeks, right? Now, friends, coming to the abortion guideline. right? It is a nice guideline of abortion. It is not very lengthy. It is a very small guideline, but actually sometime one or two questions can come from this. This is the reason I have added it, so that it will be saved with you in the form of screenshots and in the form of slides, right? Just a minute. This is an exam question. Abortion from the abortion guideline. This is a most frequently coming exam question. Anyone has seen this question in practice books? 1 week. This is the waiting time for the abortion. In the abortions, we have to ensure that the minimal delay in the abortion process and provide the assessment within 1 week of the request. Provide the abortion within 1 week of the assessment. This 1 week, you have to choose 1 week. This is an exam question. And what about the NTD prophylaxis? Anyone knows about the NTD? Sidra, Irsa? In abortion, what is the criteria for NTD?
We will give NTD if abortion done less than 10 weeks.
We will not give them?
Sorry, ma'am, after 10 weeks.
After 10 weeks, right?
After 10 weeks. Before 10 weeks, we will not give.
Yes, I have written the line at the end. Do not offer NTD prophylaxis who are having medical abortion up to and including 10 plus 0 weeks. After 10 plus 0, 10 plus 1, 10 plus 2, 10 plus 3, we have to give. But up to 10 plus 0 and they are having medical abortion, it is not necessary to give them NTD, right? Consider NTD prophylaxis for women who are RH negative and having surgical abortion up to and including 10 plus 0 weeks. For the surgical management, we have to give to all the women, right? Regardless of the gestation. Is it clear now?
For medical, if they're above 10 weeks.
Yes, exactly. There are only few important points, in this guideline, but I have just added it so that we are not going to miss it, right? We have to cover everything because you're covering a lot of things, and because of missing this, if you miss 1 or 2 questions. Now, prevention of the infection, do not routinely offer antibiotic prophylaxis to the women who are having medical abortion. In the medical abortion, you are not going to give antibiotics. Offer antibiotic prophylaxis to the women who are having surgical abortion only. And what you are going to choose? When using doxycycline for the antibiotic prophylaxis in medical or surgical abortion, consider oral doxycycline 100 milligram BD for 3 days. This is the simplest regime for the abortion and only in the surgical abortion. Expulsions at home for women who are having medical abortion and will be taking mifepristone at 10 weeks of the gestation. Offer option of abortion at home after they have taken the misoprostol. Misoprostol can be taken in the clinic or in the hospital. Like she will take the mifepristone, right? She will go back to home. She will come back after 48 hours and she will take the misoprostol, and then she will go back and she will have expulsion at the home. Now I have just made this slide. I have tried to make the doses, although it is a very, very less coming in the exam. These are not frequently coming exam, but I have just added so that you will not miss anything and you will have a precise idea. And for just complete coverage of the curriculum, I have added. Otherwise, these are not coming in the exam.
No, this time actually my friend gave exam on 17th January.
This came?
Yeah, and she was saying that the scenario was given in a SB that 26 weeks IUD was there, and she had to choose the option. And she was saying they were so confusing, and she still doesn't know what she chose.
No. Listen. 26 week story. Actually, 26 weeks is a cutoff in the GTG of IUFT, right?
Yeah,
for the IUFT,
about 26 weeks, and they opted the options of meso and mifi. So she was saying they were so close, she couldn't decide what to choose.
No, actually, in the GTG of IUFD, it is very, very clear the doses have been given before 26 as well and after 26 as well. I will be telling you in detail about that. GTG of IUFD is an old guideline, but it is very important. And they always put everything from that. This is the reason I have not added it over here. This is only for the abortions, right? These doses are only for the abortions. IUFD dose is every time they are giving. In the exam, in part 2, in part 3, this is frequently coming exam question. But abortion doses is less likely, but still I have mentioned so that you can have some time can have an idea, like medical abortion when women
same as the given for FIGO doses.
No, this is from the NICE. This is from the NICE. You have to follow the NICE.
Okay.
Yes, right. Because listen, we will go to the FIGO when something is not mentioned in the GTG and the NICE, right? In the exam, it is very important to check the resource. Like you have already told me that the IUFD doses have been asked. IUFD Green Top guideline is an older one, but still this is their favorite. Small for gestation age guideline is their favorite, right? So these are older guidelines, but these are very, very frequently coming exam questions. This is not very frequently coming, but still I have mentioned so that you do not have to go to that and open it again. This is the reason I have added. You can just have a look that women who are taking mifepristone offer initial dose after 36 to 48 hours. Actually, after mifepristone, if we will not wait for 36 to 48 hours before starting meso, then the bleeding time will be, patient will take longer to abort. This is the reason they take 36 to 48 hours so that mifepristone can have its effect.
And ma'am, in this NICE guideline, there's a box which comes again and again after 2-3 pages, which has mentioned Gamiprost as well. We don't remember that as well.
No. Forget about that. The recommendation part is that. Otherwise, they were telling actually the rationale behind the recommendations, right? So no need to go with the. I have seen those boxes. These are the big boxes, and a lot of doses have been written over there.
Yes, and then they have mentioned before 7 weeks, 7 to 9 weeks, 10 weeks. So difficult to calculate the days and then convert them to
Even
weeks.
this was, I was like this, that it will be difficult for you to remember, but I have just summarized everything on one slide so that with one slide you will be knowing everything. And now forget about the abortion guideline. My slides will be more than enough. No, this is the reason I made it, because no need to go back to that. That is not very, many questions are not coming from that. That 1 week question is coming, and other you can have an idea. Up to 23 plus 6 weeks, 400 microgram 3 hourly, up till even 25 weeks, 400 microgram 3 hourly until delivery, and up till 28 weeks, 200 microgram 4 hourly until delivery, and 100 microgram 6 hourly until delivery. 1, 2, and 3. Only these 3 figures you have to remember, right? 1, 2, and 3. Up till 25 weeks, 400 microgram 3 hourly until delivery. Up till 28 weeks, 200 microgram 4 hourly until delivery. After 28 weeks, 100 microgram 6 hourly until delivery, right?
Okay, ma'am.
This is the surgical abortion. What we have to do, cervical ripening, we can do with a meso 400 microgram, sublingual 1 hour before abortion, because sublingual is absorbing rapidly through the microcapillaries. So this is 1 hour before abortion, and vaginal dose if we given, then 3 hours before abortion, right? And I have also summarized the thing that you were saying before 7 weeks, after 10 weeks. They have mentioned a lot of things. I have summarized all this on this slide. For women who are having surgical abortion between 14 and 16 weeks, consider there are from 14 weeks onward, like this is for the 13 plus 6 weeks. From 14 weeks onward, there are only 2 to 3 options. Osmotic dilators, right? Misoprostol or 200 milligram oral mifepristone given the day before abortion. But these are never coming. You have to just remember these 3 options. Dilators we have to use, misoprostol we have to use, and mifepristone we have to use. Just remember, these are the surgical options. What anesthesia we have to use? We can use local anesthesia alone, local anesthesia with IV. IV I have not mentioned here. I will correct it. This is IV sedation, not oral sedation is not allowed, right? This is IV sedation. Then general anesthesia, IV propofol and short-acting opioid like fentanyl. Fentanyl you can use here with propofol. GA, local anesthesia plus IV sedation. These are the 3 options for abortion anesthesia. Right. So this is all about guideline. Friends, I have still a few more things. Okay. Just a minute. Now we will start. Okay, now we will start the guideline of what you want to do first, recurrent miscarriage or nausea, vomiting, and pregnancy?